We will get started in a moment. Hello and welcome, everyone. Thank you for joining us. I'm Dr. Andrew Gerber, the President and Medical Director of Silver Hill Hospital. Here I am a substitute. I'm hosting Grand Rounds in place of Dr. Jeff Katzman, who is away on vacation. And I don't pretend to be able to do as good a job as Jeff, but I'm honored to be here in his place today. We really have a quite extraordinary speaker today, an incredibly accomplished person and a wonderful speaker, Dr. Charles Dike, who will be presenting on the topic Pathological Lying, a Case for Inclusion in the DSM. I have the pleasure of introducing him in just a moment. A little housekeeping to start. Our next Grand Rounds is on June 26th, when we welcome Dr. George Bonanno from Columbia, who will present to us on the topic of trauma and the resilience paradox, the crucial role of regulatory flexibility. For those of you who haven't had the pleasure of hearing Dr. Bonanno before, I really urge you to attend. He's a wonderful speaker and does really, really interesting research at Teachers College at Columbia. But back to today's lecture. Your questions remain an important part of our Grand Rounds. I will moderate a Q&A discussion with Dr. Dike at the end of his lecture. There's a great opportunity to put forward questions and comments to Dr. Dike, which you can submit anytime during the lecture by using the Q&A link. If you would like CME or CEU credits today, and I know many of you do, please complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this event have indicated a relevant financial relationship with an ACCME defined commercial interest. It is now my great pleasure and honor to introduce our guest speaker today, Dr. Charles Dike. Dr. Dike is Professor of Psychiatry and Co-Director, Law and Psychiatry Division, Yale University School of Medicine. He is also Chief Medical Officer, Office of the Commissioner, Connecticut Department of Mental Health and Addiction Services, affectionately known here in the state of Connecticut as DMAS, and President of the American Academy of Psychiatry and the Law. So you already have a sense of the great span of his expertise and his contributions to the field. Dr. Dike completed medical school at Obafemi Awolowo University, formerly University of Ife in Ile-Ife, Nigeria, and his psychiatry residency at All Birmingham Hospital's Psychiatric Training Scheme, University of Birmingham, England. After additional psychiatric residency training at the University of Illinois at Chicago, Dr. Dike completed a fellowship training in law and psychiatry at Yale University School of Medicine and never left, much to our good fortune at Yale. Dr. Dike obtained a diploma in clinical psychiatry from the Royal College of Physicians and Surgeons of Ireland and was awarded a membership of the Royal College of Psychiatrists of England in 1998. He obtained a master's in public health degree from University of Illinois at Chicago in 2004. A past president of Connecticut Psychiatric Society, which is a wonderful organization, and for anybody interested in it, I urge you to join. Dr. Tishiana Arma is the current president, and we're actually having our annual dinner next week. You can email me or Dr. Dike offline if you'd like to come. Dr. Dike is a distinguished fellow of the American Psychiatric Association, fellow of the Royal College of Psychiatrists of England, and fellow of the American College of Healthcare Executives. He's also chair of the APA Ethics Committee and author of Ethics Corner, a monthly article discussing psychiatric and medical ethics concerns in practice. In Psychiatry News, a publication of the APA, and actually one of the best read publications in the whole entire field. Dr. Dike is a special federal government employee serving on the National Advisory Council of the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, or SAMHSA. The American Academy of Psychiatry and the Law established the Charles Dike Diversity Scholarship Award for his tireless work on diversity and inclusion and other issues pertinent to forensic psychiatric practice. His interest areas include, but are not limited to, medical and psychiatric ethics, pathological lying, management of aggression, health systems administration, and forensic psychiatric consultations, both civil and criminal. So I think you get a little bit of a flavor from that bio why he is so well qualified to be our speaker today. And it is now my honor to pass the baton over to Dr. Dike, and I look forward to your talk.
Thank you so much, Dr. Gerber. Thank you, Silver Hill Hospital, Jane Collin, and all the other colleagues at Silver Hill. It's a real pleasure to be here today, an absolute privilege. I am so grateful to you guys. and thank you for the generous introduction. I would start, the topic today is pathological lying, which is something I got into in fellowship here when my mentors at the time, Dr. Ezra Griffith and Madeline Branowski, had a case of pathological lying. And then that became something that was really interesting to me. And that has progressed over time to where we are today. But before I start, just want to make sure that I am obligated to mention to everyone that since I work for federal governments a little bit and for state government and for Yale, that everything I say here today is my opinion, not that of any of these individuals I've mentioned. Other than that, I have nothing else to disclose. So we're going to go through, this can be a 2-hour talk, a 3-hour talk, or a 1-hour talk. So I'm going to try and make sure that we bring everything together in 1 hour. We're going to have a review of pathological lying from the history, sort of historical review. Then we'll go to some of the salient clinical presentations. And thereafter, I'll shift a little bit to talking about the relationship between pathological lying and factitious disorder. And you will see why that's important. And then finally, I'll try to pull the case together for why I believe that pathological lying should be a DSM diagnosis. Unfortunately, this talk is actually best in person, because if we were in person, I would ask you all this wonderful question. If you've told a lie yesterday or today, please raise your hand. Invariably, some people will raise their hands, others will not raise their hands. And then I'll say something like, what am I doing in this wonderful city and this beautiful hospital talking to a group of liars? And then that would be if we were in person, but we're not in person. But unfortunately, actually, the fact is everyone lies, and you can't stop them. That's the truth. Sorry, I want to go back to that quotation. This is an excellent quotation about why everyone lies and you can't stop them. Of course, that's the truth. In 1942 by Sally. But I also like to this quotation here, where there is no vice so mean, so pitiful, so contemptible, and he who permits himself to tell a lie once finds it much easier to do so a second time, a third time, till at length it becomes habitual. And you wonder who gave this wonderful quote about lying. It's actually Thomas Jefferson to his cousin as far back as 1785. But in fact, as I said before, everyone lies. Literature is at least some kind of research done some time ago in 1996, which has been replicated since then, shows that college students lie or tell at least an average of 2 lies a day, and adults tell an average of 1 lie a day. The question is, what about Silver Hill Hospital staff? How many lies do you tell a day? All right. So let's get into some of the examples that I think I'll use as foundation for this talk. This individual is a professor, is Professor Joseph Ellis. He's a prominent and eminent professor of history at Mount Holyoke, National Book Awards winner in 1997, Pulitzer Prize winner, and so on and so forth. Just really, fantastic historian. Now, the interesting thing about Professor Ellis is that his lies expanded as his fame grew. Now, most people are familiar with the idea that once you come out of school, your CV is relatively scant. And so you stretch the truth about your CV. You add all things you're not really supposed to add there. But that's, I think people sort of understand that as you're coming out. But for most people, as you become more prominent and you become more ingrained in the work you're doing, your CV begins to look like exactly what it should look like. You shouldn't, the truth becomes, your CV becomes more truthful than as you would imagine. The surprising thing about Professor Ellis is that his lies actually expanded as his fame grew to a point where he got in trouble. In 2001, there was a huge write-up about him in the Boston Globe where they detailed all his lying behavior. And it was really, I think it was quite shocking to a lot of people. after which he was suspended for 1 year, and then he lost his endowed professor chair for a period. So there's a consequence to this type of behavior, which might not be surprising to most people. Now, here's a pictorial representation of Professor Ellis's lies. That he scored a winning touchdown in a high school football game. However, he never played football. And he was a platoon leader and a paratrooper in the Vietnam War. He served with General Westmoreland. He served duty in Saigon. He wasn't there. And then when he came back from Vietnam War, he joined the civil rights and became a very active civil rights participant. And then he would tell this wonderful story about what happened to him in Mississippi when he went for this, as one of the activists in Mississippi, that the local police pounded on my door at night and the state police followed my car. By the way, just as a side note, Professor Ellis's lectures were absolutely coveted at Mount Holyoke. They would fill up immediately. They were open. Within hours, they were all full because he was a great lecturer, but I'm sure it's also because he has a way with words and he has a way of presenting things in something like this. Local police pounded on my door at night and state police followed my car. So what was Professor Ellis doing during the time of the Vietnam War and the civil rights movement? He was actually a graduate student at Yale, after which he went to West Point to teach history. Some of his ex-students, upon reading the account in the newspaper, one of them made this comment: "Why should a man as successful as Mr. Ellis, whose books are those rare creatures, best-selling works of history, feel compelled to reinvent his past?" Which is really a crucial question when it comes to pathological lying. Why should he feel compelled to do this, despite the fact that he was so successful? Another ex-student said, "He seemed so genuine. Perhaps it was a fantasy he came to believe himself." Another really important point when it comes to pathological lying. All right, next example is this individual who is a judge, Judge Patrick Cowenberg, who was appointed a judge in LA in 1997, that is in Los Angeles, and then was removed in 2001. Why? Because Judge Ellis told a lot of lies. He said he was a corporal in the army, that he won the Purple Heart in Vietnam, and he would make dramatic comments in court when the prosecutors and defense attorneys and things are going on. He might say things like, "I'm having a really bad day today because of the shrapnel that is still in my groin." And then he would tell stories about covert operations for the CIA in Southeast Asia, including making a delivery in Africa, this mysterious CIA work that he was involved in at some point. In addition to that, he said that he had a master's degree in psychology. He worked for this prestigious law firm, and he schooled at Caltech, Loyola Law School, Navy Reserves, all of them false. But the most important thing is that when he was being investigated by the Board of Commissions, the Judicial Commission in California, he lied under oath. Judge Cowenberg should know better to not lie under oath. So, but why did he do it? Continue to lie, despite potential difficulties that he knew were coming his way. Judge Cowenberg was examined by a forensic psychiatrist who had done a lot of work in pathological lying. That psychiatrist said that Judge Cowenberg was suffering from pseudologia fantastica, which he describes as storytelling that often has sort of a matrix of fantasy interwoven with some facts. Psychiatrist then said that Judge Cowenberg did not have a major psychiatric disorder, despite the pseudologia fantastica. And in addition, that his pseudologia fantastica was treatable with therapy and did not render him unfit for judicial service, which is really an interesting comment to make, because it was very hard to understand the basis for the opinion that he was treatable and did not render him unfit for service. All right, the third example is this man whom everyone might recognize, Jeffrey Archer, who had lots of roles: novelist, playwright, politician, actor, athlete, and a liar. Was the former deputy chairman of the Conservative Party, member of the House of Lords, and he contested for the mayor of London, which he unfortunately did not succeed. Here's how some of his colleagues describe him. One said, when you bump into him, it's impossible to know which Jeffrey you are dealing with. The one who tells you the truth, the one who lies, or the one with the fabled gift for inaccurate perceived, or the one who tells you what you want to hear. Another colleague says, his life was a tapestry of fabrications, multiple mendacities, large and small, too numerous to list. But what was really fascinating, at least to me, was how his wife described him. His wife remarked on her husband's gift for inaccurate perceived, her husband's gift for lying. Incredible. Ultimately, Mr. Archer was jailed for 2 years for perjury, which is lying under oath, and for perverting the course of justice. Now, all through literature, pathological lying, pseudologia fantastica, and so on have been described in different ways. All of these terms have been used: mendacity, compulsive lying, morbid lying, habitual lying, and so on and so forth. It's very difficult to understand if they all describe exactly the same thing, although they are very close and they are used interchangeably. But it was Dr. Delbruck, a German physician in 1891, who first described what he called pseudologia fantastica. And this was after he observed 5 of his patients and wondered about the enormity of the lies of these patients. They were so abnormal and out of proportion that it was different from anything he'd ever seen before. And he decided that this required a special category, because it's not just your usual run-of-the-mill lying, that there's something about this that made it different. So it's a kind of a narrow form of lying. And a lot of work has gone into examining and researching pathological lying over the years, especially in the early 19th century. But somehow, after that, the research in pathological lying waned for some reason. But Healy and Healy are the 2 individuals who have spent an enormous amount of energy trying to understand pathological lying. And they had the seminal work they had done in it. And they defined pathological lying as fabrication entirely disproportionate to any end in view. Entirely disproportionate to any end in view. They said that these lies may be extensive, may be complicated, may manifest over a period of years or even a lifetime, and then in the absence of definite insanity, in the absence of feeble-mindedness or epilepsy. So Healy and Healy put their foot down that there mustn't be any associated psychiatric disorder that will account for this type of falsification, this type of lies. And they observed that the utterance of lies comes just as quickly and naturally and easily as speaking truth comes to other people for individuals who have pathological lying. But Healy and Healy were not the only people who had a definition for pathological lying. Sterling also had another, where he said all those whose lying is seemingly purposeless and who by virtue of obvious mental disease, particularly diagnosable psychopathic personality of some type, exhibit a major symptom, the lack of the ability to stick to the veritable word. So Sterling took a different approach, saying there must be some psychiatric problem for an individual to tell lies like this, and that it must be something along the lines of a psychopathic personality disorder. So you have suddenly immediately a group of people who say there is no underlying psychiatric disorder, and another who say there must be some underlying psychiatric disorder. When we examined the literature in 2005, my mentors and I, we decided to have a definition that was descriptive only, not making any comment on etiology, on any kind of psychiatric disorder that might be underlying. And so we define pathological lying, and this is actually how you will see it in the literature: excessive lying for no apparent purpose. no apparent purpose at all. Easily verifiable to be untrue, may be elaborate, may be fantastic or dazzling, may last years or even become a lifestyle. And interestingly, may be damaging to the liar, which is an interesting observation. Sometimes anyway, so this is how we decided to define it for now. I'm going to wanted to say up other things, which I'll get to later on. Therefore, pathological lying is not defined by the magnitude of the lie. Sometimes if you're having regular conversation in the street, someone says, oh, that's a pathological liar, and they're referring to the fact that the magnitude of the lie was just too much. But pathological lying in this format, in this way we define it, is not defined by magnitude of the lies. It's not defined by the frequency of the lies alone. It's not defined by the callousness of the lies. Some lies are so callous that you wonder why somebody would do that. But this does not, pathological lying as we define it, is not defined by the callousness of the lies, nor is it defined by the consequences of the lies per se. So there's a clear difference between how regular individuals would describe pathological lying in normal discourse, as opposed to how psychiatrists would define pathology and psychologists would define pathological lying in the literature, as we've said. There have been, first of all, I just want to take a moment to commend some of my psychology colleagues across the country and across the world, in fact, who have taken on this pathological lying since we wrote our paper in 2005 and 2007 and so on. And there have been a lot other ideas of how to define pathological lying. But I wanted to highlight the most recent one that was presented by Drs. Hart and Curtis, which is a persistent, pervasive, and often compulsive pattern of excessive lying behavior leading to clinically significant impairment of functioning in social, occupational, or other areas, causing marked distress and posing a risk to others or self, occurring for longer than a 6-month period. Now, what you will see with this sophisticated definition is that it's along the lines of how DSM defines diagnosed psychiatric disorders, because it talks about functioning, it talks about distress, and it talks about duration. However, when we reviewed the literature at the time we were working on this, we decided that there was primary pathological lying and secondary pathological lying. And primary pathological lying, because there are individuals for whom there clearly were no evidence that they had any underlying psychiatric disorder. And then secondary pathological lying, because there are individuals for whom it seemed like there was some kind of psychiatric disorder underlying or at least associated with pathological lying. And I'll get to that in a minute. I'll describe it a little bit more. Oh, so am I going backwards? Okay. All right. All through the years, the main controversy that has dogged pathological lying is whether the individual pathological liars recognize their lying as false, and also whether they are able to control their lying behavior. Those are the two things that have dogged this controversy, this condition over the years. Eminent psychiatrists and even psychologists, such as Schneider, Bleuler, Jaspers, Fish, have all wondered about pathological lying. They've all commented on it. They've all looked into the condition known as pathological lying. And they've all wondered if the pathological liar recognized their lies to be false or if they believed them to be true. So let's take a look at this. For those individuals who are group A, who believe that there might be some impairment in reality testing, why are they saying that? They're saying that because to the pathological liar, if you observe the pathological liar, after a while, the lies will look delusional, because to the liar, they have the worth of a real experience. So it comes across as if it is delusional because they actually look like they believe what they're saying. Others have said that pathological lying is actually a wish psychosis, that the pathological liar saw their lies as reality and then believed them. And therefore, even though it might have started off as some kind of a wish, because they saw it as reality and believed them, there's a level of psychosis attached to it. So they call it a wish psychosis. Others wonder about the unplanned and impulsive nature of their lies, that the lies seize the liar suddenly. And therefore they say, if this is happening, those individuals must not have control of their lives because these individuals have lost ability. It is happening, it's unplanned, it's impulsive. They've lost ability to control their lives. And yet others say that pathological lying is different from ordinary lies, both qualitatively and quantitatively. The lies leave the ground of reality readily. Ultimately, the lie wins power over the pathological liar, such that mastery of the lies is lost. And this is a condition that they termed systematized delirium, that the new I, the new person who is the liar, has overwhelmed the normal person. And therefore, they call that systematized delirium. Other individuals still say that pathological lies, the lies in pathological lying, are not real because those verbalizations are not consciously engendered, and the goal is not really consciously recognized. In other words, consciousness of the real situation was said to be lost in pathological lying. All right. The other group of individuals who believe that there's absolutely no way, pathological liars are not, they haven't lost reality. And these are the second group of people. And they justify that by saying that pathological lying is really just fantasy lies. They are daydreams, projected as reality. And the lying itself is the gratification. They lie only for the pleasure, the fantasy, and the pleasure that comes from. Others talk about what they call double consciousness, where one form of life, which is the real person, lies side by side with the liar, such that actually after a period, the lying person, the second person, overwhelms the real person. But at no time is the real person lost. And therefore, there's no loss of reality testing. It's just double consciousness, two individuals or two sides of an individual lying side by side, where one side is the liar and the other is the real person. Others say there can be loss of reality testing because if you energetically confront the liar with his lies, if you energetically confront them with the lies, that they may rarely admit to their lying behavior. Therefore, if you may rarely admit to your lying behavior, it can't be, you can't have lost reality. You understand what you're doing. You're just not admitting that you're lying. Others say because pathological liars have sound judgments in other matters, there can't be any loss of reality testing if you can have sound judgment in many other areas except when it comes to lying. And the fact that pathological lying has also been associated with some form of crime or criminal behavior like theft, swindling, forgery, and so on, makes other people believe that there can't be any loss of reality testing. People just wonder if the impulse that leads to literary creation and writing of books and fantasies and romances are the same that lead to pathological lying, so that there's a blurring of fiction and reality that might happen when you're looking at some really fantastic novels. Therefore, for them, at the end of the day, the pathological liar has not lost contact with reality. But this is an ongoing struggle. Did they understand that their lying is false? Did they understand, or do they have control over it? These are two things that have always worried individuals. In terms of epidemiology, this is really not a great way to look at it because Healy and Healy talked about 1,000 juvenile offenders. I mean, these are individuals who have already committed crimes. And so in those individuals who have already committed crimes, prevalence of a pathological lying was said to be 1%. In the work done by Dr. Ford, looking at 72 other cases, decided that found that the age of onset is around teenage years, but the age of presentation is early adulthood. And there's no difference in ratio in the gender, whether it's male or female. The IQ is average, so there's no difficulty with the IQ, although verbal IQ tends to be a little bit more than performance IQ. The other thing they found was that there was some kind of association with some CNS abnormalities. About 40% of individuals with pathological lying that Dr. Ford and his colleagues had examined had things like epilepsy, abnormal EEG, head trauma, or CNS infection. They didn't quite understand the connection between them, but this was just a finding. Whether this is an association or whether this is causative is unclear at this point. There's an association with white matter changes, which some other researchers have found. So let's go quickly into what I call differential diagnosis for pathological lying. An immediate one that comes to mind is malingering. However, malingering is intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives, such as obtaining financial reward, financial compensation, illicit drugs, and so on. So that's the external incentive. Or avoiding military service, avoiding work, avoiding criminal prosecution. So when you have intentional production of signs and symptoms of mental illness to obtain something or avoid something that is beneficial to you, that is malingering. There's absolutely no evidence that the pathological liar, the lies in pathological lying, have any external incentive. In fact, people have always wondered what the benefit was to the liar for the lying behavior. And where there seemed to have been some kind of benefit to the liar, the benefit is so minimal to the consequences that it still doesn't make sense. But malingering is a clearly an important differential to pathological lying. Confabulation is another one, which is falsification of memory occurring in clear consciousness in association with organically derived amnesia. There's no organically derived amnesia in pathological lying. In addition, the confabulated material in confabulation is used to cover memory gaps that are produced as a result of organic brain difficulties. There's no such problem in pathological lying. Also, the character of the memory impairment in confabulation affects mostly recent memory. There's intact immediate memory and attention and concentration. This is not what you find in pathological lying. Ganser syndrome is another differential diagnosis, but Ganser syndrome is characterized by approximate answers. There are no elaborate fantasies, there's no frequency of lying, as you will see in pathological lying. But in addition to approximate answers in Ganser syndrome, there's clouding of consciousness with subsequent amnesia regarding the episode. There's prominent hallucinations, sensory changes that appear to be historical in nature, you will find in Ganser syndrome, but they do not exist in pathological lying. What about factitious disorder? This is the closest one. And I'm going to just leave this for a minute and come back to factitious disorder. But just to state that factitious disorder, generally, whether it's imposed or self or other, is intentional production of symptoms, psychological or physical, often through false means, but really solely for the purpose of assuming a sick role. We're going to get back to that in a minute. The individual with pseudologia fantastica or pathological lying is not trying to assume a sick role at all. And so that's a major difference. Now, there are some personality disorders that might look like pathological lying. The most prominent is borderline personality disorder. As you know, the core characteristic of individuals with borderline personality disorder is often they lack a consistent self-identity and they hold contradictory views of themselves at every time or different times, and they alternate frequently. They are prone to loose thinking in unstructured situations, and they may actually have transient loss of reality testing. Then the defense mechanisms of primitive denial, idealization, and devaluation often are very clear. You can see the individual with a borderline personality disorder, even though they might have behaviors and presentations that might seem like pathological disorder, like pathological lying, other symptoms of borderline personality disorder will slap you in the face, and you will tell immediately that this is not just your ordinary run-in-the-mill borderline pathological lying. Antisocial personality disorder has also been said to be a differential. While in most individuals with antisocial personality disorder tell lies for their own benefit, there are times when they tell lies just for internal satisfaction alone. And they might tell those lies frequently for internal satisfaction, where it might become confusing as to whether this is pathological lying or antisocial personality disorder. But yet again, other symptoms of antisocial personality disorder will strike you in the face, and you will know that this is really not pathological lying, but antisocial personality disorder. Now, what about a narcissistic and histrionic personality disorder? A narcissistic and histrionic personality disorder, people often lie to attract attention. And in severe cases, these lies might become so frequent that they might resemble pathological lying. But again, other symptoms of the histrionic personality disorder will be clear, that you'll see that it differentiates them from pathological lying. Narcissistic personality disorder has also been offered as a differential diagnosis because these individuals might tell ego-boosting lies to obtain constant approval from others. And if they do that frequently, it might be confusing as to whether or not this was pathological lying. But again, other symptoms of the disorder will strike you and you will see that it's clearly not them. Delusions are really, people have wondered significantly whether pathological lying is a delusional disorder, and therefore it becomes a major differential diagnosis. But delusions are false beliefs that are strongly held despite incontrovertible evidence to the contrary, and they are not generally shared by members of the individual's cultural or religious context. Therefore, the individuals with pathological lying do not share this type of strongly held belief despite incontrovertible evidence to the contrary that are contrary to people in their general context. And although individuals with pathological lying, when confronted energetically, might admit to their lies, individuals with delusions, in the acute phase of delusions, you can't shift them. You can't shift their belief. And that is what differentiates them. But it's very clear that for some people, it can be quite confusing as to which is which. Therefore, in summary of what I just described, in conditions where there's absolutely no confusion that there's no pathological lie, it's malingering, confabulation, and dancer syndrome. And other areas where you might wonder if pathological lying did exist would be factitious disorder, borderline personality disorder, antisocial, and so on and so forth. And it's quite unclear, as I said before, whether there is a role for delusional disorder in this configuration. Here are arguments for primary pathological lying, that the pathological lying is occurring by itself. We mentioned the case of Professor Ellis, George Cohenberg. George Cohenberg, in fact, the doctor who examined him, clearly stated that there was no psychiatric disorder underlying the pseudologia fantastica. Now, going back in time, Cleckley, who was a prominent psychiatrist, who wrote this wonderful book, The Mask of Sanity, gave a case of an individual who was a successful and respected man with a doctorate in physics, whose stories were filled with exaggerations and falsifications, sometimes conscious, sometimes half-conscious. But Cleckley clearly stated that this individual did not suffer from any type of psychiatric disorder. He was not a psychopath and he was not insane, but he had this behavior that was baffling to him. And then, of course, in the literature, there's something known as pseudology ado, which is akin to Fourier ado, where the individual, the dominant partner in this particular dyad, is someone who has pseudologia fantastica. So all of this show that pathological lying can exist by itself without any additional psychiatric or medical condition underlying it. And then there are arguments for secondary pathological lying. We've talked about those CNS findings that I've described earlier from Dr. Ford's research. Whether or not those CNS findings are causative or associations are unclear. People have talked about pathological lying, that the liars are compelled to lie. And so you wonder if that is a compulsion. Is that an OCD? And then there's also the one where the lies seize the liar impulsively and suddenly. So you wonder if there is impulse control disorder in some forms of individuals with pathological lying. We've mentioned some of the personality disorders and how they can be confused sometimes with pathological lying. In fact, when I presented this some time ago to a group of medical students and residents, one of the residents said to me, "Are you sure this is not an addiction?" And actually, when you step back to think about it, that's a good point. Could this be an addiction? Has this risen to a place where an individual continues to do this for particular benefits to them, but to nobody else? despite the fact that they might get in trouble, as you have seen individuals get in trouble from their lying behaviors. There's been findings of frontal white matter changes in individuals with pathological lying. And so all of this make you wonder if there are different types of pathological liars, those who are primary pathological liars and those who are secondary pathological liars. Now let's talk about just looking at DSM, an impairment in social, occupational, and other areas of functioning. Definitely, individuals who have pathological lying will have relationship difficulties because it's very difficult to trust an individual who's a liar. There's always an issue with credibility. And after a while, it just wears you down and you break up in those relationships. What about social interactions? I mean, can you imagine, presenting your friend to others as a pathological liar in a social environment, or even presenting your spouse to others, and then suddenly they get into this behavior of lying unnecessarily, excessively, for no apparent reason? You can imagine the kind of negative attitudes people will have. By the way, calling somebody a liar is one of the worst insults you can give to an individual in this country. People have lost their lives defending their honor when they've been called a liar. So you can imagine what this would look like in social interactions. It can also lead to difficulties in maintaining a job, not necessarily in getting the job, but in maintaining it. Because after a while, people would say that you're lying about everything, and it's very difficult for them to understand when you're telling the truth or not telling the truth. And then after a while, you become a brunt of jokes, might end up being disciplined as a result of your behavior. You might lose your job or you might resign. And as I mentioned before, individuals with this behavior sometimes have difficulties with the law. So there's clear that there's impairment in social, occupational, and other areas of functioning when you have a condition known as pathological lying. What about treatment? They are very difficult. This individual is tearing his hair out because his patient has pathological lying, and you can understand how this is a problem. But the first thing to do when you see an individual is to have an elaborate diagnostic workup just to make sure that there's nothing else going on. But it's absolutely crucial to get significant collateral information from individuals who've known them at home, at their workplace, at schools, and any other area that they function. Because when you put the story together, the pattern will emerge that there's something really unusual about this person. Whether or not they've had past legal histories, it's important to subject these individuals to psychological testing, but there's no one test that would detect an individual as a pathological liar. There's no lie detector test that would detect that an individual is a pathological liar. But the role of psychological testing will be to rule out other forms of psychopathy and also cognitive deficits and personality disorders and so on and so forth that might be playing a role or not in a particular individual. In terms of treatment per se, especially in therapy, the major issue the clinician has to deal with is counter-transference issues. Because as I said before, this individual comes into your office, is lying every day, there's a new lie, and things just keep elaborating, and it's very difficult to hold them in one place, which is like shooting in the dark, as some of the therapists have described this in the past. So it's very difficult to understand how to manage these individuals. The only time you might be able to get a handle on it is for individuals who've come to you because they say to themselves, or people have told them that they have pathological lying and they need help. And therefore, you might be able to navigate some of that with them, but still it's very difficult. In one of the times I've written about this, I've talked about the potential role of medications. If we're thinking about this being some form of impulse control disorder or OCD or addictions, we can at least try some medicines that we have been trying for these disorders or these particular symptoms and see if they will have a bearing on individuals with pathological lying. Now, I don't think any of this has been tried formally, and that's also because there's really no diagnosis that you can say somebody has that you call it pathological lying that will allow you or give you the leverage to prescribe medications for them. In the legal arena, this is a real problem because the first issue that strikes you is whether these individuals are competent to stand trial. Competency means that you understand how the court system works and that you are able to work with your attorney to resolve your case. Well, if you're lying to your attorney every minute, it's very difficult for you to be able to assist your attorney in resolving your case, which was exactly the case of the individual for whom we got involved in this particular topic of pathological lying. The other question as to whether individuals can perjure themselves, like lying under oath, is a problem. As you can see, it's already happened a couple of times in the cases I presented. A bigger area, much more controversial area, is to say that the individual is not guilty by reason of insanity, that there's something about them that absolves them of responsibility for their acts or their criminal behavior. Nobody is going to buy that, even though, in fact, the question as to, because that is reserved for severe mental disorder. A severe mental disorder is clearly defined, and pathological lying will not fit that. An important element to consider is whether or not this condition is treatable. Because in the legal arena, if something is treatable, at least you can argue for mitigation and say that if we treat them, they will be better. If they go to rehab, things might be better. Therefore, judge, can you please reduce the sentence of this individual? But you can't really say that with certainty in pathological lying at this point. So these are real difficulties. Now, in trying to make the case for DSM for pathological lying, I'd like to contrast it a little bit with factitious disorder. Now, factitious disorder was first described by Dr. Richard Asher, who was a really observant and vigilant physician, a British hematologist and endocrinologist, who also coined the term myxedema madness when he observed some form of psychiatric disorder on some of his patients with hypothyroidism. So it's a really fascinating doctor, Dr. Asher was. But he described factitious disorder. And he said, like the famous Baron von Munchausen, the persons affected with this disorder have always traveled widely, and their stories, like those attributed to the Baron, are both dramatic and untruthful. Hence, he coined the term Munchausen syndrome to describe this condition. In addition to frequent lying, which he observed with these individuals, patients with the syndrome characteristically travel from hospital to hospital, across regions, across states, even countries, he observed. And they are often admitted to a hospital with apparent acute illness, supported by a plausible and dramatic history, largely made up of falsehoods. The most remarkable feature of this Munchausen syndrome, quote unquote, is the apparent senselessness of it all. That these patients often seem to gain nothing except the discomfiture of unnecessary investigations or surgical operations. Many of their falsehoods seem to have little point. They lie for the sake of lying. Now you can see now how this is sounding similar to the pathological lying definitions and descriptions we have described so far. The Dr. Asher's diagnostic criteria for factitious disorder, therefore, begins with intentional, which is conscious production of psychological and physical signs and symptoms. Now, the DSM-3, DSM-1 and 2 was silent on factitious disorder, but from DSM-3 to DSM-4 TR, it became included. And in those conditions, in those documents, they state that the best studied form of factitious disorder has been called Munchausen syndrome. That individuals with factitious disorder with predominantly physical symptoms may indulge in uncontrollable pathologic lying in a manner intriguing to the listener about any aspects of their history or symptoms. So the DSM pulls in pseudologia fantastica as a potential finding in individuals who have factitious disorder. And then they elaborate on that a little bit. In DSM-3, compulsive in quality, that factitious disorder is compulsive in quality and could not be relinquished despite known dangers or adverse consequences. Therefore, the deception in factitious disorder appears to be compulsive in quality, according to DSM 3R, and they are not easily relinquished despite known dangers or adverse consequences. So then they bring in this question of, is there a loss of control? DSM-4-TR recognizes factitious disorder, pseudologia fantastica, as a common feature of factitious disorder, but one that is not essential for the diagnosis. DSM-5 completely removes that connection. It says falsification of physical or psychological signs or symptoms or induction of injury or disease associated with identified deception is how they define factitious disorder. And the deceptive behavior is evident even in the absence of obvious external rewards. The Dictionary of Psychopathology defines pseudologia fantastica as a symptom of Munchausen syndrome that can also be seen in psychopathic individuals who create stories because of a need for continuous external stimulation. Therefore, the question for you all here is, do you think that Baron von Munchausen really had Munchausen's disorder? There's absolutely no evidence that his stories, which were elaborate and fantastic, were ever told to assume a sick role. In fact, it seemed like what Baron von Munchausen really had was more pseudologia fantastica and not factitious disorder, as people have claimed in the past. Now, let's talk about some of the common findings between the two of them. Frequent lies and deceptiveness for no apparent purpose or gain. Where there appears to be a purpose, such as to assume a sick role in factitious disorder, the cost far outweighs the apparent gain. Lies can be self-destructive, as we've seen. Negative personal consequences are not deterrent to the behavior. The lies and deceptive behaviors are senseless. They might be fantastic or even grandiose, told for a lifetime, and are difficult to give up in both conditions. When vigorously challenged, they may slightly alter their lies in pathological lying or runaway. The factitious disorder patient will leave the hospital AMA and proceed to yet another hospital within or outside the region. Therefore, it is questionable always whether the individuals in both conditions have control of their behavior. Clear distinctions. In pathological lying, the lies are broad and varied with no consistent singular focus. Whereas in factitious disorder, the lies are more consistently focused around the psychological or physical symptoms of a sick role. Here's what was found in the literature. Even in factitious disorder situations where elaborate lying is not apparent, the core elements of factitious disorder, deceptiveness, senselessness, damage to self, no apparent gain, apparent lack of ability to control behavior, and travel rather than admit deceptiveness, are all recognizable elements of pathological disorder, pathological lying. Therefore, I propose to you and I offer to you a complete difference in understanding of the relationship between pathological lying and factitious disorder. I believe that it seems clear that pathological lying is a superordinate category and factitious disorder is just a subset of the condition with a narrower medical and psychological focus. So individuals with pathological lying is broad and varied and whatever. But when it has a consistent singular focus, we call it factitious disorder. So I think the tree itself is pathological lying and the branch is factitious disorder. Unlike what the DSM has said in the past, where pathological lying was seen as a symptom that was present in some forms of factitious disorder. The reverse is in fact the case in my opinion. And I'm going to rush through this case to end, to show you how that connection between factitious disorder and pathological lying come together. This is a case of Miss Yabra, who is a former chemist and a mother of 3 children. This was reported in the Star Telegram in Texas. She was arrested in 2009 and subsequently sentenced to 10 years in prison for a charge of serious bodily injury to a child. Subjected her second daughter to 30-40 surgical medical interventions from which the daughter almost died. She caused the daughter to have surgically inserted gastrostomy tube for feeding as treatment for a reported swallowing dysfunction. You immediately recognize this as factitious disorder imposed on others. Now, she injected pathogens which she collected from her lab as a chemist and gave them to her daughter, causing her grave illnesses. altering her daughter's sweat tests, leading to a diagnosis of cystic fibrosis. She drained her daughter's blood, causing severe anemia. Daughter went into treatment, into life-threatening anaphylactic shock during infusion of iron dextran to correct the anemia. But she had a long-standing history of frequent lying behaviors herself for no apparent reason before these findings that occurred later after she had children. Here are some of them. Right after her marriage in 1998, she told her husband she was taking classes for her PhD. And she left home for classes on Tuesdays and Thursday nights for 1 year, after which she announced proudly to her husband that she had now obtained her PhD. Her husband was a little dubious about this, but wanting to support his wife, he just continued to support her, even though he thought it was pretty strange. She printed PhD on everything she had, business cards, email address, and so on. In 2001, she informed her family that she had just been diagnosed with bone cancer. And for the next 8 years, her cancer ruse grew more elaborate. She would claim it had spread to her brain, lungs, destroyed her hearing, prompting her to learn sign language, and later reportedly get cochlear implants. So you can see clearly this sounds like pathological lying or pseudologia fantastic. She claimed she beat the cancer twice, even moved to Alabama for 8 months for treatment. She could not get anywhere else. While reportedly undergoing chemotherapy, she suddenly announced to her family she was now pregnant with twins. She wore maternity clothes, named her unborn twins. One day again, she suddenly informed the family that she had miscarried, that the twins were gone at 5 months of pregnancy due to complications of what she said was her cancer treatment. She had a mini funeral for them. She claimed she had twins cremated, after which she kept a sealed urn of their ashes on their fireplace mantle. She later bought a 6-foot concrete angel for a memorial garden in their backyard and tattooed angel wings with 5 stars on her back, each star representing one of her quote-unquote 5 children, including the twin girls she reportedly miscarried. You can see. Ms. Yabra's lies were numerous, unfounded, often illogical. They preceded her factitious disorder presentation. Later, some of her lies provided an opportunity for her to assume a sick role or to be the center of medical attention, but many others had no such connection. In all situations, the negative consequences of her behavior far outweighed whatever benefit or goal that could be gained. Lies continued in prison despite overwhelming evidence to the contrary. The journalists who went to see her in prison and interview her left with the same impression that she just gave them, lying upon lying upon lying, and she's just difficult to catch up. Factitious disorder is a DSM diagnosis, but pathological lying is not. Then you ask yourself, why is that so? Because patients with factitious disorder cannot be ignored. There's absolutely no way you can ignore them. They present a significant distress to a healthcare system that hold the system hostage, if as it were. Patients who are most likely to present in psychiatry, neurology, emergency, internal medicines, there's no way you can avoid them, as they will just make your life miserable. They consume an exhausting amount of staff time and drain the physical and emotional reserves of clinicians, also drain financial resources of a system taking care of them. There's this term, surgical addiction. Therefore, people would find a way to find an explanation for this disorder that is causing so much difficulty, and hence factitious disorder is a psychiatric diagnosis. But because pathological lying does not have the same type of problems, and people just are undetected, they are under the radar. Therefore, it's difficult it's not surprising that there's no diagnosis of pathological lying, even though they present exactly the same. And in fact, one is more, I would say, encompassing than the other. But it's really important for us to have pathological lying as a diagnosis. It's going to encourage more research. There'll be more systematic studies. At least you can talk about what you're researching. You can obtain grants because you're researching a condition. To decrease misdiagnosis, to improve knowledge, better evaluations, all of this is really important. And I just want to credit also Drs. Hart and Kurt for this definition, this suggested DSM diagnosis. So you can see there's criterion A, B, C, and D, and so on and so forth. So in conclusion, pathological lying and factitious disorder have a lot in common. They are both quite controversial. They are baffling to clinicians. They involve frequent lies and deceptiveness for no apparent purpose or gain. Where there appears to be a gain, the cost to the patient or the pathological liar, which is like painful and stressful medical and surgical procedures, loss of job, criminal convictions, far outweighs the apparent gain of the lies or deceptive behaviors to the individual. Talked about the lies being self-destructive, but even that is not enough to deter the individual from carrying out the behavior. We talk about the lies and the deceptive behaviors being senseless or fantastic or grandiose or a lifestyle. It's still difficult for them to give it up. When vigorously challenged, whether it's pathological lying or factitious disorder, the liar or the individual might run away, admit their lies, move on to something else, or run to a different city if it is factitious disorder. While in pathological lying, the lies are broad and varied with no consistent singular focus. In factitious disorder, they are more consistently focused around psychological, physical symptoms and a sick role. And end with this quote: some people have lived their falsehood so long that they could pass a lie detector test about their stories. Really interesting comment by this retired Navy captain. And I say thank you all for your attention. I know this was long. Thank you, and I open up for any questions or comments by members of the public. Thank you.
Thank you, Dr. DK. It is not every day that I say this, but that Grand Rounds could have been a primetime TV show, and you would have gotten millions of people watching that, not just in the field or in psychiatry. It is so interesting and compelling, and right on the border of, I think, what draws people to our field in many ways, which is this boundary between the normal, just as you started out by saying. Some degree of lying is very compatible with kind of everyday normal experience, and yet at the extreme, including some of the stories you presented, feels so almost unfathomable. So your call for more research and more investigation, and that starts obviously by putting it in some sort of a classification system, feels very compelling to me. And if they opened it up for a vote, I imagine most of us would vote for this. Now there are tons and tons of questions, and I have some myself, but I'm going to resist the temptation and try to synthesize some of the questions that are already coming in, and I'm sure that many more will come in. So please do add more questions, and then I'll do my best to get to them. I'm sure I won't get to all of them. So one question that came up in a bunch of different forms was the question about any potential links to neurobiology. I think we've gotten very used these days to that when we're thinking about schizophrenia or depression or anxiety or even addiction, to think about what the neurobiologic correlates. In fact, Dr. Berv, I thought, had a very thoughtful suggestion. Are there any clues, for example, from confabulation, which obviously you've convincingly described that those are very different things, but can we learn anything about the neurobiology of pathological lying from other potential disorders that may have that as a component? Any thoughts you have about that?
That's an absolute fantastic question. And I think, let me tell you, first and foremost, what makes research in pathological lying challenging. The individual first will admit that they are a pathological liar. And then you have to have enough of those individuals who admit that they are pathological liars. And you can imagine how that's a problem, just off the top of your head. Nobody wants to be called a liar, even if they admit that they have a problem. So to be able to gather enough of those individuals and subject them to research to look at what's going on in their brain is challenging. Therefore, what people have done is actually, I think, I guess is the best they can do, is get individuals who have some form of psychopathy, some form of psychological difficulties, like the juvenile offenders that Healy and Healy looked at in 1926, but also other individuals have looked at individuals who met Hare's psychopathy checklist definition of psychopathy. And then they've attached pathological lying to it, which is problematic because, as I just showed you, many individuals have no psychopathy. And so when you look at the brain of those individuals, they conducted MRIs and other radiological investigations of them, and they found increased white matter changes and a change in the white-gray matter ratio in the brain, suggesting that most of these individuals have some dysfunction that allows them to have a lot more white matter. And is that causative? Is that an association? Is this linked to psychopathy, or is that? It's very unclear. But in fact, these people are looking at whether there is a biological basis for this. And unfortunately, right now, I think the audience that they're getting their data from is really flawed. And so it's very difficult to make a definitive statement about it at this point.
Very, very interesting. But I imagine if we were to move to a DSM diagnosis, it would be possible potentially to fund more research and so on. So
that is correct.
One of the questions that's come in a bunch of different forms, and I'm going to attempt to kind of synthesize, is around the question of insight. And you've mentioned it in a couple of contexts, but I wonder if you could say a little more about to what extent, in your experience, do individuals with a diagnosis of pathological lying have insight that there is a problem? And for those who don't have that insight, once they gain insight, does that demonstrate that they're on the road to improvement, or are the two independent? I wonder if you could just say a little bit more about that relationship.
So this is exactly the main issue, isn't it? People say, is this psychotic in nature? Is there a loss of reality testing or not? And obviously, when you think loss of reality testing, you begin to wonder about insight. Is it present or isn't it present? I think that most people, at least the ones I have seen, eventually discover that they have a problem, because it has led to problems in their relationships. It has led to problems at work. It has led to problems at school. There was this individual whom I actually saw recently, who was a college student, who's been in college for like 6 years now, really not doing anything, but lying to his parents, who are scattered all over the world, that he's going to graduate soon. And so when time comes for graduation, he'll come up with new stories why they can't, even though they're already in the US. And he'll come up with new stories why it's not going to happen. So after 2 or 3 times, you can imagine the stress this is causing the whole family. And so he himself is now quite distressed by it. So he understands that there's a problem. But understanding there's a problem and being focused in trying to change the material, change the presentation and behavior are two different things, because it's really hard to give up. And I think, obviously, in the literature, in terms of trying to look at the treatability of this condition, some have talked about, in the past, it was all psychodynamic psychotherapy, and now, cognitive behavioral therapy, habit reversal therapy. And, there might be some positive changes here and there. Again, not knowing the type of pathological lying, not knowing other issues related to it, is very difficult to really make a firm comment about it. But there are suggestions that some people might improve in terms of how they catch the lying behavior on time and change it before it becomes a problem. But it's a real difficult area. I don't think at this point, certainly in my own assessment of some of them. I mean, I haven't seen as many as my psychology colleagues have. But the ones I have seen, I don't think you can stand back and say there's a loss of reality testing or loss of insight, as we would say when we are dealing with somebody who's really psychotic. I haven't seen that per se.
Got it. Very helpful. A few of the questions, I think we're trying to get at a little more of the etiology, and asked whether there are any commonalities that you've noticed or the literature reports on early life history or attachment style. Is there any way to trace even some of the cases to some kind of early distortion of relationships that might be related?
I think it's a wide range. There are those who have developmental histories that are problematic of trauma, of abandonment, of neglect, and so on. But there are those who have none. I've seen both. It just, again, that's what makes it, at least at this point, challenging. So people have theorized that individuals with pathological lying are stuck at the fantasy lying stage of children. As you know, children use fantasy to deny reality as a form of development. But after a while, they drop the fantasy and they become real. But individuals with pathological lying have been said to be stuck at that level. But I think there's a wide range of backgrounds, of developmental histories of the individuals that makes it hard to pin down a particular developmental style versus the other.
Thank you. So you and others may be noting that it took me a long time to get to a question that I'm sure you get every time, which is a potential connection between politics and pathological lying. And I'm going to try to ask it not as to comment on individual politicians, but rather to comment on, the polarization in our country, which we talk about all the time these days, seems to suggest that people's belief about truth is very dictated by their identity with an organization. In other words, I remember seeing a study once that if you show different clips to people who identified as very partisan Democrat or very partisan Republican, they saw different. They reported seeing different things in the very same videos, meaning obviously that we look at things through a lens. And so what I wanted to ask you is do you see a link in pathological lying to political climate? For example, is there more pathological lying today than there was 50 years ago in your estimate? Are there more politicians who are pathological liars? Are there more just more visible people who have these difficulties? I'd be curious, any light you could shed on that would be helpful.
Yeah. This is a loaded question. I'm sure you know. But I think what has happened in this country is when we begin, or at some point, we began to accept lies. They no longer had the force that he had in the past. People came up with terms like alternative facts, which means that, well, this is your own fact, this is my own facts, and they're alternative. And so you hear terms like my truth, my own truth, which is, there's only one, what is my truth? What is your truth? So I think we've come to a point where we have normalized certain behaviors, normalized certain presentations as acceptable if you are within a certain context. And the idea that two individuals might look at the same set of facts and present it differently or have different opinions is also born out of the fact that if you are, I think it depends on what type of social media you are choosing to consume, right? There's certain social media you can consume. Is the earth flat? If that's that social media will tell you, yes, of course it's flat. And there's all kinds of things they tell you as to why it is flat. And if you ask the question and your social media feed is slightly different, it is, of course it's not flat. It's, it's, I don't know, spherical or round, and they give you all the facts. If you are stuck in one context, all what you're going to get is the story that supports that context over and over and over and over again. And after a while, if it is presented to you one way, you're going to see what you've already known from your own context. And so it's not a surprise at all that two different individuals looking at the same facts will have a completely different understanding of those facts based on what social media has allowed us to now do. So yes, the advent of social media, the advent of conspiracy theory, the advent of individuals from outside the country who are trying to manipulate us as well, has influenced how people look at what facts and what facts are not. I don't think it means that pathological lying is more. I think I don't think that if you place the definitions of pathological lying, place those behaviors under the lens, that they will meet pathological lying as we've described it. Because they will give you examples of why they are saying what they are saying, even though you think they are wrong. But they have a lot of examples to support it based on the social media feed that they support or they consume. So it's very difficult. And in terms of politicians saying, is it to see that a politician or another is a pathological liar? Again, in order to be able to define something, you must have adequate information, have adequate data, and the data must be, gotten from people who know the person, who works with them in different contexts, and you put it together to have a pattern. Most people who are in the media have a media personality or a media persona or a media presentation, which can be completely different from how others will see them in class or in school or in their home. And so it's very difficult to decide just based on what we see and snapshots that somebody is one or not or the other.
Yeah, I mean, what you say is so interesting because it makes me think about the shifts in our society. Not as you're saying, meaning that there's necessarily more pathological lying, but what social media has enabled us to do is to, in a way, curate a set of facts that aligns with a particular identity. So, before the internet, I suppose you could do it in other ways, newspapers, but it was certainly slower. It wasn't as efficient, and therefore, what we talk about is postmodernism, this notion that there are different narratives, all that have some truth depending on how you look at things. One from that perspective could see as accelerated by technology, which is I have to think about it.
Even news media. So if you're depends on what news media you watch,
Right.
what news medium you watch all the
And
time.
it didn't used to be that way, right? When I was
Exactly.
growing up, there were essentially three channels, and they all said more or less the same thing. There wasn't that option, so it's created this. That's very
Because
interesting.
it's not news this time, it's now um, discussions.
Right.
So you take an issue and then you have a panel of 4 people discuss the issue.
Right.
And so they are discussing it based on their context. And therefore it's not quite news anymore. If that's what you're listening, you're going to buy what they're selling, which might be completely different from another news media who's taking the same set of facts of another 4 groups of people presenting it in a different way.
Yeah. Makes sense. So let me switch to a different topic that came up in a bunch of the questions, and that's to go back to this distinction between borderline personality disorder and pathological lying. And I think you very convincingly argued that certainly the sum total of what you're describing, pathological lying, is not explained fully by borderline personality. But the questions about it, the relationship between the two, and so I wanted to ask is does one see an overrepresentation of borderline symptomatology among individuals with pathological lying? So not just the extremes of mood, but suicidality, impulsivity. You mentioned unstable relationships. In other words, even though they're not the same thing, do you see them as having a fairly close relationship?
I don't think that there is an overrepresentation of borderline presentation in individuals with pathological lying. I don't think so. I think they share some things in common, which is, what I just described about, holding contradictory views of themselves at different times, and then responding. But, the intensity of relationships is different, right? So you're all good, you're all bad, and this is very unstable, intense relationship. You don't have that in pathological lying. The difference in the relationship difficulties in pathological lying is because one member, this one of the two, is tired of your lies and they can't trust you. It's just, and so they don't want to continue. Whereas in borderline personality disorder, it's just the absolute intensity can be overwhelming and it's just so hard. And then suddenly they're trying to kill themselves or doing all kinds of things. It's just too difficult. And so while there might be difficulties in relationships, the quality is different in terms of what leads to separation. But of course, individuals with borderline personality disorder might present in a way that makes you wonder if some of these presentations are pathological lying. But that's just one subset of the whole picture. When you take a look at the whole picture, you're going to say, oh yeah, that might be some pathological lying here, but this individual clearly has borderline personality disorder.
Yeah.
I don't think the reverse is the case.
It would be an interesting thing to go through a sample of individuals who have been diagnosed with borderline personality and see, in a way, are there misdiagnoses along the lines you're saying? That would be interesting. So some of the questions I got were very practical, had a very practical question, which is, given how little it sounds like we have done systematically to research this question, both in terms of understanding the pathophysiology as well as the treatment, what would be your clinical recommendation if one of us were to identify such an individual in our practices? Do we refer to a forensic psychiatrist or psychologist, for example? Are there resources available, or do we do the best we can? And if so, how do we go about trying to treat them?
Well, I mean, I think I'll recommend that you read some of the books, recent literature and books that have been produced. And I sort of mentioned Doctors Hart and Hart twice in my presentation. They have a book recently that came out which talks about their own experience. And what they've done is they've gathered all what people have written and done in the past and tried to present a way to look at them. I think that you can certainly engage in your own treatment. I don't think you need to refer them to anybody. I think you just need to understand what the issues are. Ask yourself whether you have cognitive behavioral therapy skills to engage them, because that's really what you're trying to do. You're trying to change how an individual perceives the world or thinks about the world, and trying to help them change it in a way that's more adaptive in terms of their behaviors and their feelings. So it's really a question of, do you have the skills to do that type of cognitive behavioral therapy? Do you have the skills to do other forms of therapy? I mean, even dynamic therapy in some cases, or some form of eclectic psychotherapy of different types, depending on who you have. Because oftentimes our patients come with many other things as well, of which that just might be one thing. So you might be looking at all the different ways to encourage and engage them. And so I think, like everything else, if it comes to a point where you think your skills are limited, then it's important to refer them on. I don't think the idea is to refer them to a forensic psychiatrist. I think that's really, the forensic just brings in law and crime and all that. But regular individuals who might be working in this area could be psychologists. It could be some social workers who've really taken some time to look at this. And so, but I also recommend that an individual who sees this person tries to treat them themselves. Now, if you're a doctor, you might also decide, you know what, maybe I should try some medicines we use for impulse control disorder, or OCD, and by the way, there might be reason to do that because there might be some kind of mood problems that might justify the use of a mood, something that we use for OCD or impulse control disorder or addictions and so on. So you might want to try those things and see, but I think it's really you, working with patients as always.
That's very helpful. Um, so I know you touched a bit about this in your talk, but there are a couple questions about the relationship between pathological lying and addictions. And I think that the link obviously people are making is in the way you describe this being a habitual behavior that often feels to people outside their control. And obviously we've talked a lot more about behavioral addictions these days, whether it's gambling or internet or sexual addictions and so on. And I wonder if you could comment a little bit more about potential relationships between the concept of an addiction and pathological lying.
I think that, as I said, when the resident raised the question, I thought it was an important and interesting question. I think what happens in addictions is that there's an initial intention, right? So you intentionally use substances. And then after a while, you lose control. It becomes like you can't control yourself anymore. And as things are happening, there's a whole change in the brain chemistry, and you just continue to do this. Whether or not the pathological liar intentionally starts to pathologically lie, I don't know for sure if that's how this starts. I think, as I said before, what was striking about Professor Ellis being that the more his fame grew, the more his lies grew, which is also quite unusual. Because yes, most people would intentionally start to stretch the truth in their CVs, just make it look a little bit something. But after a while, you just drop all those things and then you continue with what is more realistic and more truthful. Is it possible that pathological liars will start off trying to just do this initially, and then after a while it grows and becomes fantastic and it's great, and they can't control themselves, and then even if they're going to get in trouble, like Judge Cohenberg, who should know better as a judge and still did that, I don't know. So it really begs the question whether there's a form of addiction in it. But that's why I think it's an important differential.
Yeah. John Tamarin, a psychiatrist who was our director of research at Silver Hill years ago, asked a straightforward question. He said, can you describe a treatment, either by yourself or someone else, of an individual with pathological lying and an outcome? I'd be curious to have an example of someone who was treated and whether they got better.
When I started working on this pathological line, I immediately realized that I have seen patients like this all my life. I remember I was a resident in Chicago and I saw this woman who had never been to France, who was from Southside Chicago, really sort of close to indigent. And she would come and tell me fantastic stories about what was happening in France, in Paris, and her life there and other people. And every single day is a new story. Very baffling. I don't think we succeeded in treating her. I think after a while, when we began to sort of gently confront some of the lies and gently challenge the lies, I think after a while she stopped coming. I am not the expert in treatment of pathological lying. I can tell you that. I can tell you that what I have done is actually read a lot of what other psychologists have done in the treatment of pathological lying, and psychiatrists, by the way. And I think there certainly have been some successes, but there have been much more non-success in the treatment of pathological lying. And they've all been CBT or other types of psychotherapy. And as I said, dynamic and so on. So I am not an expert when it comes to pathological lying and treatment for it. But I welcome, again, I think this is why it's really important for us to have a diagnosis. Because you can't say, I'm treating this individual for pathological lying. The insurance company is not going to cover it. Nobody's going to cover that. And therefore, most people would have a different diagnosis of what they are treating, even though at the bottom, they know that what they're treating is mostly pseudologia, fantastica. But so it's hard to know, it's hard to answer that question without a uniform diagnostic entity that directs what we're doing, and we can compare notes and say, okay, here's the effectiveness or lack thereof of this treatment.
That makes a lot of sense. Well, there's still other questions I haven't gotten to, but it's almost 1 o'clock, so I'm gonna leave those to people to either read some of the works that you discussed or to reach out independently. But I did want to say just an incredibly interesting and stimulating talk. I think you made such a compelling case that this is an an inadequately understood and underappreciated diagnosis. And people sometimes ask, well, what's the DSM for, right? This is what it's for, is to identify entities that we need to understand better. And when you think about the things that we now have in the DSM that we didn't years ago, people say, does that mean everybody's getting worse? No, it means we have a finer way of describing and studying these disorders. And certainly you've made a compelling case that pathological lying in this relationship with factitious disorders, you've said, deserves to be there. So thank you for presenting that to us, and thank you for the wonderful work that you're doing. It's always an honor to have great speakers, and I hope that our audience will come back to future grand rounds. Maybe we'll invite you back, soon, Dr. DK, to speak on another one of the topics.
Thank you so much. This has been a pleasure to be here, and thank you for inviting me. Thank you for your kind words. Really appreciate it. Thank you.
All right. Take care, everybody, and you will be left back in your offices, and we appreciate you joining us for this time. Goodbye,
Thank you.
everyone.